So have you started yet? Yes. May I
Yes.
know? Yes, that's good. Okay. So have you completed, did you get the portfolio verified? Your portfolio
Yes.
verified?
Yes.
Yes. Yes, that's nice. And what about ATT? Have you applied or still
For
wait?
which one?
ATT? So once
What?
you get your authorization to test, once you get your portfolio completed, okay, so you need to apply for ATT,
Okay, I don't
authorization.
know.
Yeah, did you get your portfolio? In the sense, is it completed?
I think so,
No,
yes. I
no,
got
yes.
an approval from APRA, so it is approved. Yes.
So in that case, they would be mentioning there itself, like you will have to contact NCSBN to get authorization to take test ATT. Didn't you get something mentioned there? So once in your email?
Maybe no. I
Yes,
didn't know
possibility.
about that. I'll check it.
Yeah. You need to check.
Yes.
Okay. So once you complete your portfolio, so you need to apply for ATT. So
Okay.
after that only you will get a reply from NCSBN. So saying that you can within this stipulated period of time you can appear for test. You will have to then book for exam. Okay.
Okay. Yep. Thank you.
So this process has to be completed. See, please, those who don't know, please start with your portfolio first. Okay, at least those who haven't started with any process, because this process takes time. So that's why. Okay, so it will take previously portfolio used to get completed by 1 month, and ATT was taking around 2 weeks. And within after 2 months, you were allowed to attempt exam. Okay, so whereas now it's taking more time. Portfolio itself is taking around 2 months, more than 2 months, sometimes even 3. Okay, and if your documents are not appropriate, so you will have to resend, so further time will be extended. Okay, so then after that, when you apply to for ATT, so ATT is also now taking more time. Yes, Janine is telling that it took 10 weeks. Oh my goodness. So after 10 weeks you got your ATT. So that
So
is the
how
queue.
can we do that? It's like on email or
Which one?
the ETT something.
ATT, yes, you need to. I mean, they have given their link in the once you get your portfolio completed. So they
Okay.
have a link mentioned. There is a link. You need to click on that. So you need to first create an account in Pearson. Okay.
Okay.
So
Yeah.
after you create an account in Pearson, that link will take you directly to the NCLEX Pearson site wherein you need to register there. And after that, they will guide with the steps. You will have to
No.
complete. Yeah.
Yes, I'll do
So
that.
that's very important. Okay,
Thank
so for others who haven't started with any process, please start, because by the time you complete your course and you can sit and prepare for 1 or 2 months intensively. Okay, so then after that you need to attempt. Otherwise, this course would be a waste, because because now since you are regular, you learn many facts that will be fresh in your mind, isn't it? So many concepts will be fresh. So if you take more time, in the sense, if you haven't started with your process, it will take around 4 months, more than 4 months next to attempt your exam. So therefore, so start with the process, the initial process, those who don't know how to carry on or how to start with. So our team will be helping you out there. Okay, so it will be assisting you. Please contact Pravina or Nemi. So they will be guiding you with the steps that is required to register first with APRA, okay, and after that to apply ATT. So that's very important. Complete these steps initially, okay, because it's a time-consuming process. See, Janine says that for ATT it took 10 weeks. In the sense, that's really a surprising fact. Usually ATT you'll get before in the sense after you apply by 3 weeks you need to get ATT, because now could be long queue. So that's why it's taking time to complete all the documents processing. Okay, so therefore please apply, please start with your process for writing NCLEX, attempt NCLEX. Okay, otherwise this course is of no use, isn't it? Okay, so let us start with today's session. So I'm just looking at the number of students who have joined. Okay, fine. So let us start with today's session. And today I'm going to discuss about gastropediatrics. as well as some of the medications aspects under pediatrics, right? Okay, so let me start with today's session. I'd like to share my screen, and I'm sharing my screen. The first condition that we are going to discuss today is on cleft lip and cleft palate. Okay, so cleft lip and cleft palate. By you would be having a basic idea about this, isn't it? So whereas NCLEX related point, you may get confused here and there. But what's this actually? Is it a congenital defect or acquired?
It's
Yes?
congenital, ma'am.
It's congenital. Yes, it's congenital, isn't it? So what could be the causes for this cleft lip and cleft palate? The picture you are seeing is of cleft lip, cleft palate, in the sense it is a little more in the sense inside. Okay, so palate. So I had a picture of palate. Where did it go? It's deep inside within. Okay, so in the sense the palate would be open. Fine. So this is the picture of cleft lip. Okay, this cleft lip, the causes could be many, in the sense mainly any infection during pregnancy, or if the mother was infected with rubella, or any even genetic factors, any abnormal chromosomes, or if she was exposed to any harmful medications or radiation. Okay, so these all could be the contributing factor for cleft lip as well as cleft palate. Now, what's the main problem here? Cleft lip, basically, you have two kinds here. One is unilateral. Okay, so unilateral, and this is bilateral. Unilateral and bilateral. Okay, so what could be the initial main problem here? Any answer? When a baby is born with cleft lip and cleft palate, what could be the main problem? Yes?
Drinking milk.
Feeding, the problem with sucking, swallowing and all, isn't it? Yes, that is the main problem here. Apart from that, so there could be some breathing difficulties also, so which is rare, but still you will have to monitor that. Okay, so sucking problem, feeding is the major problem that is encountered. So because of this because of this defect. Okay, so now usually there are certain aspects that you need to remember under feeding. Okay, so both for this cleft lip and cleft palate. So I would be explaining that. So, but before you, these are the main problems you need to understand. So one is feeding difficulties and sometimes even airway problems. Okay, so airway problems in the sense the client, the babies, since the tract and all is very small, you know, so very easily the tract can be blocked with secretions. Okay, so that will make them difficulty to breathe. So airway problem is also very I mean, so it's like the obstruction may not be that common, but still airway problems are usually seen here. Okay, so now these are the potential causes, as I already discussed: medications, exposure to virus, radiations, maternal alcohol intake, smoking, okay, genetical and environmental factors. Fine. So now what are the interventions that you need to focus here? Mainly, since swallowing is a problem, so you first have to check for the baby's ability. The assessment has to be made, because like for each child, the ability to suck, swallow and all differs. So what is the problem encountered with each child? Okay, so the ability assessment is very important. Fine. So after that, you can provide with some modified feeding techniques, in the sense there are certain special bottles. Okay, so even the special nipples are there, so that will enable them to I mean, so that will enable them to feed without any distress. Okay, so there are special bottles, nipples and all modified techniques are there, so which you will have to educate about these aspects. Okay, and while feeding, make sure that the baby is held in upright position, and only small amounts, like all of a sudden you should not feed them with a lots of milk, whereas small amounts but regular burping is also needed here. Okay, so these are the simple ways what you can how you can educate. Apart from that, there is an ESSR method, so which is enlarging the nipple, stimulate the sucking reflex, swallow, rest. In the sense, you should enlarge the nipple, so let the baby suck and swallow, and after that give some time. Okay, so you need to make sure that the baby has swallowed. So whatever the milk that is placed or whatever is placed in the mouth, so that has to be swallowed. Okay, so otherwise, so that can end up having breathing problems. Sometimes it can aspirate. So therefore, ESSR method is an important method that is involved for cleft lip and cleft palate. Okay. Yeah, so mainly for cleft lip, surgery is done. Surgery both for both conditions. Surgery is the ultimate measure that will help in preventing the further problems. Okay, so whereas surgery for cleft lip is much more easy, and wherein it involves suturing. Okay, where the cleft is there, you know, so their suturing is provided, and this is done before 6 months, usually after 3 months, but before 6 months. Okay, so please note the timing. So cleft lip surgery is usually before 3 months, but after, so before 6 months, but after 3 months. Okay, so between 3 to 6 months, usually the surgery is needed. And depending upon the depth, so a surgery may not be over in one step. It can require multiple steps. Multiple steps are mainly needed for cleft palate repair. Okay, so where the hard palate is open, you know, so in that condition, the multiple surgeries are required. It may take 2 or 3 or 4 stages also. Fine. So, but after the surgery, after the lip surgery specifically, so lip protection. Okay, so because a child can usually it will feel something is blocking and the child can become restless, and thereby it can pull off the suture line and all, isn't it? So therefore make sure that elbow restraints are kept. This is fine. Okay, so elbow restraints are considered as okay for a child after cleft lip surgery in order to prevent the suture disruption. Okay, so that's needed here. Fine. What about cleft palate? Cleft palate in the sense the hard palate. The palate is open, and here also the modified feeding bottles are there. Okay, so where the teeth, the nipple is actually modified in the bottle, and thereby the child is made to feed. Okay, but even after the surgery, the surgery of cleft palate usually can be done after since by the time the child reaches 2 years. Okay, it has to be performed. In the sense, after 6 months, anytime the surgery can be performed here. So whereas, so before 2 months, because before 2 months the surgery, the repair should be completed, because that is the time wherein the speech development and all starts, isn't it? So if the child has to develop his speech normally, in a normal way, the child should have hard palate closed. Okay, so therefore, so it's usually recommended period of surgery for cleft palate is before 2 years, but however after 6 months. Okay, so after 6 months. Fine. So now, whereas the cleft palate care is very, very, very important. Okay, so let me add on a few NCLEX points. So that's very much needed here. So before the surgery itself, see, I told you at least a minimum of 6 months gap is required here for hard palate. Okay, because that reduces the chances of further complications. The baby has to be a little mature. Fine. So, but during this time, the child is at high risk of developing ear infection. Please note down this point, ear infection. So during this period, so if you get a question wherein the child is having a hard palate, cleft palate, okay, and you find on observation, you find the child has breathing difficulties with you can find some drainage, discharges through the ears, okay, what should be your immediate action? So immediate action should be to notify the physician, okay? So notify the concerned person, the HCP. So because it indicates ear infection, or we also call it as what? Otitis media. Okay, middle ear infection, because the hard palate and the ear, it's closely connected, isn't it? So the chances of ear infection is high here. So therefore, the child has to be monitored for these aspects. Okay, yeah. So then, and usually these are all the basic aspects that you need to know. Avoid the use of oral suction or placing objects in the mouth, such as tongue depressor, thermometer, straws, spoons, forks, or pacifiers. Pacifiers, remember, so this also can come under options of your question, where pacifiers are usually not allowed for a child born with cleft palate. Okay, see, one physician or one pediatrician or a pediatric surgeon is not going to decide what has to be done here. For cleft lip and cleft palate, it is a team approach. Okay, so there will be speech therapists, so there will be even plastic surgeons. Okay, so and all will be present, and based on all of their recommendation, the type of surgery and all will actually be determined here. Okay, yeah. So palate also the same thing, the same in the sense the feeding is one such problem, whereas feedings are usually started through bottle, and based on the surgeon will decide. Okay, so how the feeding has to be initiated, because as I already told you, for every child it is not in the same extent the cleft palate is formed. So each child it differs. So therefore, based on each child's unique problem, so like in the sense that the problem is identified, assessment is made, and then the surgeon will be deciding what best kind of feeding can be initiated for the child. Okay, yeah, but the normal measures are like, so the special bottles are there, and you need to check for infection and all those aspects. So is that clear? Okay, yeah. So that was about the cleft lip and cleft palate. Right? Okay. Let us move to the next condition, tracheoesophageal fistula or tracheoesophageal atresia. What do you understand by this? Trachea is a separate part. It has to be separate, which has to connect to the lungs, isn't it? So an esophagus should get connected to the stomach, isn't it? So now here what's happening? In this fistula, the trachea and the esophagus are getting connected. Just imagine how the child could be. Yes, how the child could be, like in the sense when trachea and esophagus is connected. So, or sometimes there is esophageal atresia, in the sense esophagus will be ending just as a blind pouch. It doesn't have any connection. Okay, you can see here. So these are the numerous kind of fistula and atresia. So this is how in a normal child or a normal person it has to be separate. Okay, so whereas in atresia, you can see there, this is atresia, like esophagus has ended as a blind pouch here, and the other part of esophagus is connected to the trachea. Okay, there is a fistula. The same thing, this is another one, double fistula. Even the top part is also connected to the trachea, and the lower part of the esophagus is also connected to the trachea. Okay, so these are the different kinds of esophageal tracheofistulas and atresias and all. Okay, so now what could be the major problem? I want your answers for this. I want you to think and give the answer. How do you identify that the child is having some problem? What could be the initial symptoms? How do you know, like the child has some problem?
Respiratory distress.
Regurgitation, vomiting.
Vomiting. Yeah, exactly.
Abdominal
Vomiting
distension.
Abdominal distension.
Abdominal distension.
Respiratory distress.
Respiratory.
Yes, respiratory distress. And
choking wife.
choking, very good. So this is the main answer as I wanted, choking. Okay, because as the child takes the feed itself, it will enter into the trachea, isn't it? So the child starts to choke here. The baby starts to choke. Okay, so that is one important, choking, and severe further problems with oxygenation and all can mainly happen here. Okay, yeah. So let us see the important clinical features. The first one will be, there will be always drooling. Okay, you need to remember the 3 C's here: coughing, choking, and cyanosis, unexplained cyanosis, regurgitation, vomiting, abdominal distension. Okay, so respiratory distress, and of course pneumonia can happen, aspiration pneumonia mainly. Okay, so aspiration pneumonia because the milk enters into the trachea causing infection to the alveoli or the pneumonia, right? And the child, the baby will be restless. Of course it has to be when these problems are there, isn't it? So these are the main symptoms. These 3 C's you need to remember. Okay, so they are very the 3 C's of this problem is coughing, choking, and cyanosis. Very important. Fine. So definitely surgery has to be carried out here, and like pre-operatively you can keep the child in warmer with humidified oxygen, and if the child has breathing problem, intubation, mechanical ventilation. NPO status is maintained soon after the problem is identified. IV fluids, okay, and even sometimes the antibiotics are started. So these are the initial pre-operative measures. Okay, yeah. Post-operatively, so of course you need to monitor again for respiratory distress. IV fluids, antibiotic, parenteral nutrition can be initiated here. Okay, so strict intake and output. You need to know whether whatever intake is there, so what's the amount of output. Daily weight. Sometimes, so the child can be dehydrated also post-operatively, because infants, babies are at high risk of dehydration. So this is because, so if in a normal adults are having, what's the amount of fluids in a normal adult? Around 60 to 70%, isn't it? So whereas infants are having nearly 80% of body weight as fluids. Okay, so therefore very quickly when they can get dehydrated if they are having infection or any of these problems. Monitoring for dehydration. Sometimes when parenteral nutrition is there and when the child is on IV fluid, sometimes there could be fluid overload also. So for that, you need to assess the vital signs again. Okay, so to check whether there is fluid overload or distress or whatever it is. Okay, and if the child was having, based on the problems, okay, so if the air, if there is pneumothorax or fluid has been accumulated in the chest, then chest tube replacement is advised. Okay, yeah, and sometimes when the child is on chest tube, you need to check for infection. So the infection is seen as purulent drainage from the chest tube, increased temperature, WBC, and all. Okay, so and sometimes the feeding could be through gastrostomy tubes also. Gastrostomy tubes in the sense, so the tube is directly inserted into the stomach. Okay, esophagus and trachea has undergone repair, and it takes some time to heal, isn't it? So until it gets totally repaired and healed, you are not supposed to disturb those parts. So therefore gastrostomy tube can be placed, fine, and you need to even monitor for the placement and other aspects of the same. You understand, fine? So these are the most common post-operative care that you will have to provide. Very importantly, please remember about NPO, pre-operatively NPO, keeping the child on NPO before surgery. Okay, keeping the child in upright position, so all the time. Okay, and about suctioning, and also they are the interventions that are provided pre-operatively. Okay, and post-operative also we discussed the same aspects to be seen. Okay, so is that clear? Yeah, so that was about So esophageal atresia and tracheoesophageal fistula. Okay, yeah. So moving to the next condition, hypertrophic pyloric stenosis. So what do you identify or what do you understand by looking at this picture? Pyloric, yes, narrowing of the pylorus, isn't it? So this is nothing but the pyloric canal is narrowed between the stomach and the duodenum. So just imagine, now here I want you to think, I don't want you to refer any information or refer from anywhere else. I just want your brain to get activated, okay? I want you to think because I want your answers from your side. So what can you expect here? What all could be the assessment findings for pyloric stenosis?
Projectile vomiting.
Projectile vomiting.
Projectile vomiting. Okay, very good. Yeah. Apart from that,
Olive shaped
Dehydration.
dehydration. Okay. Then
Baba's
abdomen
Metabolic alkalosis, ma'am, due to vomiting.
due to vomiting. Yeah. Metabolic alkalosis secondary to vomiting. Okay, fine. So then,
Electrolyte imbalance.
sorry. Electrolyte imbalance. Okay, so these are some speeches. Okay, so let me focus here. Yes, forceful and projectile vomiting. So this is very important. Okay, because there is an obstruction, therefore forceful and projectile vomiting. So this is one important finding. And hunger irritability. Yes. So this is another, because there is from stomach to the intestine, the food is actually not moving. So therefore, or very little amount of food is moving, and thus hunger and irritability is very common. Olive-shaped mass in the epigastrium. Okay, so olive-shaped mass in the epigastrium. So how can it be? So you can look at this picture here. See, so in the epigastrium region, so there is because of the pylorus. Okay, so there is enlargement around the just above the pylorus, and olive-shaped mass is nothing but you can see here when like I mean, so just right to the umbilicus. Okay, so there is some mass getting formed, so that is the enlargement of the just above the pylorus. Okay, so because of that you will find this olive-shaped mass. Fine. And also when feeding is provided, okay, so you can see that a wave kind of movement, okay, so in the sense, so a peristaltic waves, like when the child is fed, you know, so the stomach is here in the sense when the food when the fluid moves down, so this movement you can actually see here. So because of the obstruction here, the pressure will create a movement here, so that peristaltic wave movement also is very common here. Okay, yeah. And of course dehydration, alkalosis and all, so are the other clinical findings that are required here. See, so these all things you generally know, right? Always for NCLEX while you study disorders, because thousands and thousands of conditions you are going to learn. Knowing all the clinical findings for every condition is very difficult. So at least remember the ones you didn't know and the ones you felt it is new or that was a new learning for you. Just remember only those points and write down the same. Okay, here forceful projectile vomiting, olive-shaped mass is important. Other ones are the ones you generally can assume, of course, the child would be having, isn't it? So whereas these things could be something important, and just write down these 2 points. That's enough. Okay, don't make note of everything. Okay, that's not going to help you. Only the important ones you need to make note of the same. Okay, yeah. So the child will be on in like I mean, so you need to monitor for this one episodes of monitor vomiting episodes and stools, daily weights, small frequent feeds, like oral fluids and IV fluids. Yes, you need to check for dehydration, electrolyte imbalance. Pyloromyotomy is the procedure that is done. So wherein through the muscle fibers, an incision is made and the opening, it is opened up. Okay, so pyloromyotomy. So there is, you can see the procedure here. So through which the pylorus is incised and we try to open it up. Okay, so that is one procedure that is usually done. But post-operatively also, make sure that the baby, the child is fed slowly. Burping should be done. Okay, so and you need to be very careful while handling after feeding. Okay, yeah, so these are the other important aspects you should remember. Okay, yeah. See, metabolic alkalosis is secondary to vomiting. Okay, metabolic alkalosis in the sense what? So what's happening there? The pH level is rising. Okay, so because the bicarbonates, when the acids are getting lost, you know, so the bicarbonate is getting accumulated, and that's why so the child will be having metabolic alkalosis. Always vomiting causes metabolic alkalosis. Remember always, okay? V causes AL, VAL, you can remember, and diarrhea causes acidosis, metabolic acidosis, DAC. Okay, just remember wild DAC. This is important, fine? So vomiting causes alkalosis and diarrhea causes acidosis. Okay, so this is very important, fine. Okay, so moving to the next aspect here, next condition, that is intussusception. Intussusception. So where did we learn this in the previous class? Did we learn this somewhere in the previous?
Intestinal obstruction.
Yes, under intestinal obstruction. Okay, the causes for intestinal obstruction. One such cause was intussusception. So what's actually happening here in intussusception? So the bowel, the small bowel can get inside the large bowel, or sometimes the large bowel also can get inside the intestine. Okay, so this is what happens in intussusception. The exact cause is yet, in the sense, there are many assumptions for these causes, but still you need to, in the sense, the exact cause is actually not known. Okay, so that is what we can say. Like in the sense, usually when the obstruction happens, so the condition or the reason is yet not very clear. Fine. So, but what can you find here? So, especially when there is intestinal obstruction, so of course there will be vomiting. But what would be the vomitous color? Any idea? What would be the vomitous color?
Green.
Green, yes, very good. Why it is green? Why
Because
it
of
is
the
green?
bowel.
Because of the bile, yes, the
Bile.
bowel content. The bowel content is coming out, isn't it? So that's why, so there will be bile stained fecal emesis. So that is green in color. Okay, so this is very important. And of course, jelly-like stools containing blood and mucus. So the bowel sounds differ. It can be hypoactive or even hyperactive. Okay, tender, distended abdomen, sausage-shaped mass in the right upper quadrant. Fine. So some mass you will generally find. And of course, abdominal pain is all very common when the intestinal obstruction is present. Okay, remember, so always you can get questions in different ways. Sometimes, so this is where I say you need to apply critical thinking. What is this critical thinking? In the exam, so they might give a question, so wherein they say which of these findings can indicate immediate notification to call for a doctor or to provide to immediately notify a doctor. They would be giving many aspects like vomiting in newborn or green color vomiters in newborn. So likewise, okay, so you need to then think vomiting and all is very common in newborn. So because they generally have GERD, so gastroesophageal reflex, because their esophageal sphincter is not well developed, and when the stomach is almost 3/4 full, easily it keeps coming out. Okay, vomiting is very common in newborn. They throw up they throw up milk all the time, isn't it? So until their esophageal sphincter matures, they keep throwing up the milk. That's very common. But so in vomiters, if there is green color finding, so then that is a concerning factor, because green color indicates that bile has come out. Bile has come out. Bile, how it should move actually, bile juice should be mixing with the food and it should get out through the fecus, isn't it? So whereas if the bile is coming out in the sense, so there is some obstruction in the intestine. Okay, so there is some obstruction in the intestine, so that's why the bile is coming out. So this will require immediate notification. So this is how the NCLEX questions appear. Okay, so you will learn many aspects directly, but you will have to apply it indirectly. Okay, yeah, so these are some aspects regarding the intussusception. And of course, because of this intussusception, so the bowel rupture can happen. We have already learned about the signs of perforation and shock, like fever, increased heart rate, changes in the level of consciousness, blood pressure, respiratory distress. Okay, so these are all the indications of shock. This also you can, based on these aspects also, you can get questions, critical thinking, based on critical thinking aspects. Okay, so then antibiotics, IV fluids, NG decompression. Okay, check for see presence of bile stool, brown stool. Yes, this is very important. Okay, if the stool is brown, so then that indicates the intussusception has reduced. Fine, so intussusception has reduced. Now, if the stool color is not changing, or if still the problem exists, there are many measures through which this problem can be corrected or problem can be resolved. So that requires a careful evaluation prior. Okay, the commonly done procedure is hydrostatic reduction. See, hydrostatic reduction in the sense, so this is where the child will be monitored continuously in the ultrasonography. Okay, the images are continuously taken, and the child status is, the abdomen is constantly monitored on the screen. Meanwhile, air or fluid is actually introduced into the intestine. Okay, so this will exert pressure to the telescope the part, and thereby so it will come out, or it will get normal on its own. Okay, so that is something we can call it as hydrostatic reduction. Okay, so you can see here, so this is just, I would like to play a video. See, there is an obstruction here in the transverse. I don't know how well this is clear. Okay, you can see here there is an obstruction, and now you can just see the air is introduced, and then this will be reduced. Okay, yeah. This will be done multiple times. Okay, so through reduce this problem or to cure this problem. Okay, so this is just a way through which the hydrostatic reduction, in the sense, in order to make you clear with the concepts, I just brought in a video, so that will the focus is to make you understand how this actually works. Okay, so that is something about hydrostat. Even sometimes barium enemas are also used. Now, newer advanced measures are also there, so which is used to treat this intussusception. Okay, so to resolve this intussusception. Okay, yeah. And after the intussusception, you need to check for the stool color. So it should be brown, and if it's brown, it indicates the problem has resolved. Okay, yeah. So that was something about the intussusception. Fine. Okay. So next we are moving to another condition called as Hirschsprung's disease. Hirschsprung's disease. Have you heard about it? I think there is a spelling mistake here. I don't know where did it go. CH was there. How come it Hirschsprung? Okay, so HIRS. Oh, I'm getting confused with the spelling. Can anyone help me with the spelling? Hirschsprung's. Yeah, here it is.
HIR.
C H.
Yes.
Yeah,
I see it.
okay. So So this is the spelling. Okay, please note this correct spelling. HIRSCHSPRUNGS. Okay, Hirsch Springs disease. Now, what is this? Hirsch Springs disease. By looking at the picture, so you would have got some idea. Okay, so this is also called as congenital aganglionosis or a ganglionic megacolon. Okay, so what does this means? Which means that ganglion cells, aganglionosis in the sense, the presence of ganglion cells, you cannot see there, okay? So, or the ganglion cells are actually absent. So, any idea about this ganglion cells or why it is or what is the purpose of this ganglion cells? Ganglion cells, yes? What's the function? Any idea?
Peristyle.
It will help in movement. Okay, so I mean, so this will help in the sense the bowel. Okay, so after so this ganglion cells have got a basic role in letting the stool flow. Okay, and also it will relax the bowel. So that is how the ganglion cells are work. But meanwhile, these ganglion cells, like I mean, so they the ganglion cells are nothing but, so they are the final endings of neurons, we can say. Okay, so they convey information, like in the sense, like they will make the bowel to understand that it is for defecation or the time for defecation, and then like I mean, so defecation and all will happen here. Okay, so that is the purpose of this ganglion cells. Now, in Hirsch Springs disease, mainly, this is congenital again. So these nerve cells are the ganglion cells, okay? So they are actually missed here. So there is no nerve cells here, okay? So without these nerve cells, the muscles are not able to move the bowel contents through the colon, okay? And thereby what is happening? All the bowel contents will be backed up there itself. So that is the problem. So only if ganglion cells are there, so the muscles of the bowel get stimulated. Okay, so that will help in movement of the contents. When this is not present, so all the fecal content will be backed up. Okay, and that will block the bowel. So this is what happens here in the case of Hirsch Springs disease. Okay, so you need to understand what happens in Hirsch Springs disease. Fine. So now, what could be the treatment, or what you will be finding in child, in newborn, and all. So this is a picture, so that will show you how in a normal person. So this is the colon and the rectum. It has to be. Okay, whereas in Hirsch Springs disease, the colon will be swollen, and the rectum will be shrunk. Okay, so this is because of the absence of the ganglionic cells, and you can see the fecal impaction here. Okay, yeah. So now the clinical findings are very important in the sense, in newborn, the main problem will be failure to pass meconium or stool. Okay, failure to pass meconium or stool. So refusal to suck, abdominal distension, and again bile stain vomitus. So these are the important points in newborn, the characteristic findings. Okay, so whereas in children, the stools will be ribbon-like, foul smelling, failure to gain weight and delayed growth, abdominal distension, vomiting, and all is actually there. In children, the ribbon-like, foul smelling stools, you are able to, they are the clinical findings here. Okay, so I hope you can relate with the reasons why this happened. But remember, these are very important points. Okay, yeah. So now initially before surgery, of course, surgery is the treatment here. So initially before surgery, all of a sudden the surgery also is a multi-step surgical procedure. So initially we can provide some rectal irrigations before surgery. Before surgery, rectal irrigations and all are actually provided. That will help to clear out the fecal infection. Okay, because if it is not cleared out, so then what will happen? Rupture can happen. Okay, so therefore, but you need to understand, like when before surgery, if the child is having some problems like fever, okay, so and diarrhea, too much of diarrhea. See here, so that's why I told you, like, you need to note the clinical findings. So the child will either, if in this problem, the child will either be having failure to pass meconium or stool, abdominal distension and all are normal in newborns, in the sense for this condition. Okay, in children usually they will be having these problems, but if the diarrhea is profuse with fever and all, you know, so then that indicates the child would have been infected, that could be infection of that colon. Okay, so that is very dangerous. Infection of the colon would have actually happened. Okay, so you need to monitor for these aspects. Fine. So then all these rectal irrigations and all are actually performed. And after that, like the surgery is planned and the surgical treatment will be carried out. But you need to, after the surgery, yeah, there are certain aspects that you need to focus here. Okay, like measuring the no rectal temperatures. These are very important. Pre-operatively, you will be focusing on the weight, abdominal girth, antibiotics and all. Okay, so mainly after surgery, no rectal temperature, but rectal irrigation is permitted before surgery. Okay, after surgery, no rectal temperatures. So remember these points. Okay, yeah. So then NG tube, sometimes the stoma is made there. So until the part heals, you know, the child will be on stoma, like colostomy is actually created there. So till the bowel, the surgical region heals, so stoma will be there. And once the surgical region is healed properly, you know, so then the stoma will be closed. Okay, so this is how it is carried out there. So in the case of Hirschsprung's disease, fine. Okay, yeah. So these are some important aspects. Always you need to check for diarrhea, electrolyte imbalance, and these problems are very common. Okay, yeah. Coming to the next aspect, vomiting and diarrhea. So they are the very common aspects in the case of children, isn't it? So whatever it is, vomiting or diarrhea, so let the child vomit or let there be diarrhea, that is not a problem. But if the child becomes dehydrated, that is the problem. Okay, monitoring for the signs of dehydration is very, very, very important. See, dehydration are basically staged in 3 levels. So mild dehydration, moderate, and also severe. So mild in the sense what? So only 5% of fluid if it is getting lost from the body. So we call it as mild dehydration. So if it is a 5 to 8% of fluid is lost, so then that is moderate dehydration, and greater than 12 or 15% of fluid is lost from the body, so that is severe dehydration. Okay, so severe dehydration is actually indicated as any of these two by focusing on any of these two following signs. Okay, so either the child can become unconscious with sunken eyes or with sunken eyes and skin going back. Any of these findings indicate that, so there has been severe dehydration. Urgently hospitalization, urgent hospitalization is very, very, very required here in severe dehydration. Okay, so because in children, if they are dehydrated, the reviving possibility is a little complicated, because they are, as I told you, their body weight is 80% made up of water. So especially in infants, okay, newborns and all. So therefore you need to, when the child is having diarrhea and vomiting, under the health education always, the ones that you give to parents are very important, you know that, isn't it? So all the pediatric topics, you will be finding the health education that you will have to provide to parents. So there you need to inform them about the signs of dehydration. Inform them about the significance of keeping the baby hydrated. Okay, so they are very important. Now, some dehydration in the sense sunken eyes, thirsty and all these aspects. Okay, so based on that, so you will have to decide what has to be done. Right? So please note the signs of dehydration. This is very important for NCLEX. Okay, signs of dehydration: sunken fontanel, reduced level of consciousness, dry mucous membranes, the mucous membrane will be dry, reduced skin turgor, tachypnea, fast breathing. Okay, so tachypnea. See, in tachypnea will be there both in fluid volume deficit and fluid volume excess. But how the respiration varies, the pattern of respiration differs. If our body is having very less fluid, so we will be taking deep breath, fast, deep breath. The respiratory rate will be high, but there will be deep breaths are taken. If the body has more fluid, if our body has more fluid, so then the breathing will be shallow. Okay, so shallow breathing. Fine. So here tachypnea is there, but the depth of breathing is increased here. Okay. So apart from that, oliguria, tachycardia, hypotension, sudden weight loss, reduced capillary filling time. Okay, so it will take greater than 5 seconds. Eyes sunken, tearless, sunken fontanel, sunken eyes. So these are all the important manifestations of dehydration. Okay, so this can happen even when there is vomiting also, for both vomiting and diarrhea. So monitoring for these aspects are very, very important. Okay, yeah. So in case of severe dehydration, so you will not feed anything orally, rather you will put the client on NPO. Fine. So for mild and moderate dehydration, oral rehydration therapies and all can actually be started. Okay. Yeah. Moving to the next one, abdominal wall defects. Abdominal wall. So mainly two defects you are going to learn here, because in a neuropediatrics, you have already learned about the meningocele, meningomyelocele and all. Okay, so here under gastric, mainly the abdominal wall defects, and of course, inguinal hernia also comes here, but since we have covered under the adult disorders, I'm not going to discuss the same here. So hernia, see hernia and many of the other like GERD problems and all are there in pediatrics too. Okay, so since we have already covered in the adult disorders, so it's not been discussed here. So now let me focus on two important abdominal wall defects in child, so in a newborn. So that is, first one is omphalocele. Omphalocele in the sense what? So in through the umbilical ring, so the abdominal contents are coming out. Fine. So, and what should be your immediate aspects? Cover this with a sterile gauze. Okay, sterile gauze, because chances of infection is very high. Sterile gauze you will have to cover. So that is the initial aspect, and the child should be taken for surgery. Okay, yeah. So that is about omphalocele. And also you have something called as gastrochysis. Gastrochysis in the sense what? The intestine, see here in omphalocele, the abdominal contents were coming out. Okay, so whereas here in gastrochysis, the intestine is peeping out through the lateral portion of the umbilical ring from sideways and all. So the intestine is actually coming out. Okay, the care is also same here. So the care that you provide is also the same, just like in the omphalocele and all. And surgery should be immediately performed here. Okay, so that is very important. Is that clear? Fine. Okay, so these were some topics. Apart from that, so there are two other conditions which I already discussed under nutrition. So that is celiac disease and lactose intolerance. Were you clear about that? Celiac disease in the sense what? What is celiac disease?
Allergic
Yes.
to gluten.
Allergy to gluten. Very good. What are the four important food components? Which
Bro.
diet? Bro diet.
Mainly
Rye,
rice,
oats, and
oats, and wheat.
Exactly. Intolerance to gluten, that is mainly the protein component of wheat, barley, rye, and oat, broad diet. Okay, so now you will find the child having diarrhea, abdominal pain. There will also be muscle wasting too. Okay, so muscle wasting will also be there. So electrolyte imbalance, even the child can end up having severe acidosis and all because of excess diarrhea. Diarrhea is very common here. Okay, so there will be severe acidosis. Okay, yeah. So usually lifelong elimination of gluten sources is recommended, whereas some after many years can get back to normal. Their body will start to accept for a few, but others depends. For each person, it actually differs. Okay, so lactose intolerance also you are clear about that, isn't it? Yeah. So now that was all about the gastropediatrics. Okay, yeah. So now let me take a few questions on the same. So just a moment. Just open the question. Okay. Fine. So here is the first question. Please give the answer. Diarrheal stools. The nurse is reviewing the lab report results for the infant with diarrheal stools. Which analysis of the lab report is correct? Color is yellow, pH is 6.8. Odor is sweet smelling, occult blood is positive. The color is characteristic of normal stools. The pH
No,
is
ma'am.
abnormal and the stool is alkaline.
No, ma'am.
The odor is uncharacteristic for diarrheal stools. The stool is discolored due to visible blood.
Last one, ma'am.
Occult blood, ma'am.
So you mean that yellow color stool is the discoloration? Do you think so? See, here you have to understand the difference between the occult blood and the overt blood. What is the difference? Occult blood and overt blood. Overt blood is the blood that is visible in the stool. Okay, so and usually if the overt blood is more, so the stool color will usually change. Occult blood is hidden, so only after analysis you will come to know that there was blood in the stool. Okay, so usually color change is not evident through occult blood. Fine. Okay, yeah. So now here what about the, so therefore you can't go in for option 4 here. Okay, so what about the option 3? The odor is uncharacteristic for diarrheal stools. Diarrheal stool, do you think it will not be sweet smelling? It can be. Okay, so it can be sweet smelling. So it is not an uncanny, it can be sweet smelling, it can be foul smelling also, diarrheal stools. Okay, so it will change. So therefore, so option C also you cannot select here. So it can either be sweet or foul smelling. Whereas what does the option says? The odor is uncharacteristic in the sense it should not happen, or this kind of odor should not be present in diarrheal stool. No, it's not like that. It can be. Okay, yeah. And what about the pH?
Is acidic.
It's acidic, isn't it?
Yes.
So do you think this is normal?
It's not normal.
It's not normal. What should be the this one? pH of stools? Alkaline. Okay, so it should be alkaline. Yeah, so this is not normal. And of course, the normal one is the color is characteristic of normal stools. Okay, so yes, the color is yellow And this is a characteristic of, especially since it is for infant. If it was adult, brown color is the characteristic finding. So whereas infant's normal stool color is yellow. Diarrheal, and usually because infants, it will take lots of time for the bile to be processed and all. Okay, so therefore usually the color is yellow, and for an infant this yellow stool is actually normal. Okay, yeah, so option 1 is the right answer. Yeah. So moving to the next one. An enema is prescribed for 20-month-old who had severe constipation. The experienced nurse observes the new nurse perform the procedure. Which action by the new nurse requires the experienced nurse to intervene? Which means something wrong, or one wrong way has been, a wrong way of the procedure is done by the new nurse. Which is that wrong way? Obtains the enema with a 500 ml of solution from the unit's supply. Places the infant on a bedpan for the duration of the procedure. Inserts a small soft catheter rectally for instilling the enema solution. Stops instillation when cramping is noted and resumes when it is passed.
D.
Why?
Second one.
That is normal. D is normal in the sense when cramping is
Yeah.
seen, so
No,
you
ma'am.
generally stop.
Second one, B option, ma'am.
Why?
The infants cannot be placed in.
Second one, but why did you say? You think that the child should not be placed on a bedpan?
Yes.
20 months. It's only 20 months. Just around 1.5 years and a bit higher. That's it. So of course, bedpan. Whereas option 1 is wrong. Why? Because 500 ml is more. The quantity is more for an infant. Okay. For infant, it should be less than 250 ml. Please note this point. Okay. So it should be less than 250 ml. And therefore, so this is the answer. So that is actually wrong. Okay. Yeah. So hope you have learned something. Fine. Moving to the next one. The child is to have a breath hydrogen test to evaluate for malabsorption syndrome. Which instruction is most important for the nurse to include when teaching the parents about the preparation needed for the test? Okay, so about the preparation needed for the test, right? So just go through the options, but meanwhile, so let me also ask you, do you have any understanding about the malabsorption syndrome? What's that? What's that malabsorption syndrome? Simple, okay? Malabsorption syndrome. The body is not absorbing, or the intestines are not absorbing. Okay, so that is something we can call it as a malabsorption syndrome. Okay, so now in order to know this, there is a breathing, test. Okay, so in the sense, this is basically will through the breath, it will enable to identify the problem. Okay, so now here for this malabsorption syndrome, so there is an important teaching being given by the nurse, but what is more important to be added about the preparation needed for the test? Be sure to administer the prescribed antibiotics an hour before the breath hydrogen test. Serve meat, rice, and water for the evening meal before the test. Avoid other starchy foods. Give the child an enema for bowel cleansing the morning of the breath hydrogen test. Encourage fluids just before the test to moisten the child's mouth for blowing into the mouthpiece. For peptic ulcer also, this urea breath test is done, isn't it? So in the similar way, so this is also the urea breath test I had explained, isn't it? So in the same way, like here, so what do you think? So usually through this test, you check for malabsorption, what has not been absorbed properly. Option 1, option 4. Which instruction is most important for the nurse to include, which means that, so which is right? Okay, which is right? In the sense there are 3 options which are not needed for this. There is one option which is right. Which is that?
Ma'am, antibiotic may be avoided before the test.
Antibiotic, yeah, antibiotics, in the sense antibiotics should be avoided. So that is right. Okay. So whereas, so here, so what does the client say? So be sure to administer the antibiotics. So you cannot consider this, isn't it?
Wrong.
Antibiotics should not be, you are right, antibiotics should not be given. But here, it's not giving an answer for the question. Please understand, don't get confused. The child is supposed to have a breath hydrogen test. Now, which instruction is most important for the nurse to include when teaching the parents about the preparation? So be sure to administer, and no, we are not going to administer. So this answer cannot be selected. Serve meat, rice, and water for the evening. Avoid
Option D.
other starchy foods.
Encourage fluids before the test.
Option D is correct.
D1,
D.
D. Encourage fluids.
encourage fluids just before the test to moisten the child's mouth for blowing into the mouthpiece. Give the child an enema for bowel
Ma'am,
cleansing.
not just before. Not just before.
Okay,
one.
so I can also get some answers. Yes, Gibbons has given second as the answer. Okay, what's the reason, Gibbon? Any answer from your side? Richa? Any explanation from your side? Yes?
That starchy food will be detected in that hydrogen test.
Okay. What about the third option? Why is it not considered? Like give the child an enema for bowel cleansing. So bowel cleansing is it required? Bowel cleansing, when do you do? Bowel cleansing
Before surgery.
before, especially, yeah, colonoscopy and all. And, yeah, for that bowel colonoscopy and all, bowel cleansing is required. Here, it's not required. So option C also you can actually eliminate here. Okay, so encourage fluids, and some of you answered the fourth one. The fourth one says encourage fluids just before the test to moisten the child's mouth for blowing into the mouthpiece. How relevant is this? Yes, before the test, the child has to be on NPO. Okay, do you remember? Yes. For urea breath test also I had explained the same. So the person has to be NPO here. Okay, so therefore, in the sense, the encouraging fluids are also not right. In that way, when you think, even though you don't know the reason for the second one, so you can just give your understandings, your thinking can be applied for the first and the other options, which is actually wrong. And therefore, the second one can be right here. So whereas the reason for second one is here, they have specified meat, rice, and water. Okay, so these actually, so these food, so they will, meat, rice, water, and all are actually having already hydrogen, this one, like I mean, so here this is a breath hydrogen test, isn't it? So now if you provide with these food, so right, rice and all, so that rice has got more carbohydrates, which means more starch in it. Okay, so this will interfere with the hydrogen that is already administered during the test. Okay, the result will not be accurate. Fine. So that is why option B is considered as the right answer here. Okay, so serve meat, rice, water for the evening meal before the test. So avoid other starchy foods. Okay, see, meat doesn't have much carbohydrate, so rice has, but that's okay. Mild form, water is absolutely fine. But here the nurse is telling to avoid other starchy foods. Okay, because high levels of starch will generally interfere with the testing of the result. Okay, so that's why option B is considered as the right answer here. Okay, so that's why you need to make sure that in order to avoid basically for this breath hydrogen test and all, so the food that is basically high in starch and all will interfere with the results of the test. Okay, so therefore, like, this is the right answer. Option second is the right answer. Okay, yeah. So, and sometimes we may not know the reason for the second one, why it can be, but still when you are confused like this, at least go with the other options and apply your thinking there. Okay, yeah. We'll move to the next one. The nurse is caring for the 2-month-old hospitalized child for dehydration secondary to gastroenteritis. Dehydration has occurred secondary to gastroenteritis. The nurse's assessment findings include irritability, pulse is 180, okay? So respiratory rate is 48, BP is 80/50. All the aspects of dehydration and dry mucous membrane. So which additional assessment finding supports the moderate dehydration? So that is the question. Which additional finding supports moderate dehydration?
C. C.
C?
Yes.
C? Yes.
Yeah.
Okay. Yeah. So no. C. C is the right answer. Okay. So capillary refill 2 seconds is normal, right? 2 seconds is normal. That's normal. How can it indicate dehydration? Again, so that's normal. Less than 2 seconds is normal. It has to be there. Okay. So thirst. What does thirst indicate? Thirst is, see here the question focuses on moderate dehydration, isn't it? So thirst and all, intense thirst and tears are absent in the case of severe dehydration. Okay, so in severe dehydration, under those category, we learn that there is intense thirst and absent tears, whereas sunken anterior fontanel so indicates that the child is moderately dehydrated. Okay, yeah, so therefore option C is the right answer. Moving to the next one. The experienced nurse is observing the new nurse caring for an 11-month-old child who is 12 hours post-operative from a cleft palate repair. 12 hours, okay, it's been 12 hours. So which nursing action requires the experienced nurse to introvert? So something wrong has happened here. So in while caring, okay. So which is that requires the experienced nurse to introvert? Uses a suction catheter to remove oral secretions, cautions the nurse assistant against giving toast on hard foods, removes an elbow restraints to check the skin and IV, administer pro-prescribed analgesics intravenously.
First one, ma'am.
A.
First one, that's very clear
Okay.
and easy, isn't it? Yeah. So what will happen if suction catheter is kept?
The suture will be altered. The suture on
The suture, it will disrupt the suture.
And the bleeding.
Yes, that will cause bleeding and all. Okay, so it will disrupt the suture, and therefore, so this is not considered as the right answer. Okay, yeah. Moving to the next one. The nurse is preparing to care for the infant newly diagnosed with esophageal atresia with tracheoesophageal fistula. Which nursing action is priority?
B.
Priority, newly diagnosed.
B.
B,
A.
A, ma'am. A.
Same.
hmm?
Assess
See,
lung sound.
infant newly diagnosed with esophageal atresia. The baby is already diagnosed.
B. B.
B,
B.
isn't it? Yes,
B.
B. So that becomes the priority, withholding the oral fluids. Okay. So assessing, why do you do assessment? So before diagnosing the condition, assessment is required. So whereas here it's already diagnosed, and assessing sounds are important. So to check whether there has been any aspiration and also to know that. Okay. So whereas the question is, so which is the most priority action? Priority is to withhold the oral fluids, because if you give oral fluids, aspiration will happen. Okay. So, and that can cause many other life-threatening symptoms. So therefore, so withholding oral fluids takes up the priority role here. Always when you consider priority, you need to think like, if I select which answer, will the complication be avoided? Or in what way, if I select an answer, so is that the answer so that is going to prevent the complication from happening? So you need to think in that way when you get priority questions. Okay, so that will help to get the right answers. Yeah. Moving to the next one. The nurse is caring for the infant who has respiratory distress and copious oral secretions. Which finding would prompt the nurse to notify the HCP with a concern about possible tracheoesophageal fistula? The nurse is caring for the infant who has respiratory distress and copious oral secretions. Which finding would prompt the nurse to notify the HCP with a concern about possible tracheoesophageal fistula? Yes? Think. Yes? So with this question, I'm also leaving you for a break. Okay, so before we come after, so you can take 10 minutes break now. So, and I'm not going to stop sharing my screen. You can also think the right answer for the same. Okay, so we will be back after 10 minutes. Okay, you can also take break.
ਮੈਂ ਰਾਮਪਾ ਜੀ ਤੇ ਰੂਮ ਕੇ ਚੱਲੀ ਨਦੀ ਸਭ ਸੇ ਇੱਥੇ ਨਹੀਂ ਸੀ
ਇੱਥੇ ਸੀਸੀਪੀਪੀ ਥਾਇਰਾਇਡ ਦੀ ਕਦੋਂ ਮਿਲਦੀ ਹੈ ਬਿਮਾਰੀ ਪਹਿਲਾਂ ਉਹਦਾ ਟੈਸਟ ਕਰਾਓਗੇ ਫਿਰ ਦਵਾਈ ਸ਼ੁਰੂ ਹੁੰਦੀ ਹੈ ਵਿਖਾਓ ਰਿਪੋਰਟ ਉਹਦੀ ਤਾਂ ਨੀਡਲ ਦੀ ਥੋੜੀ ਢਿੱਲੀ ਆ ਫਿਰ ਵਾਪਸ ਆਪੇ ਚੱਲ ਜਾਊਗਾ
ਫਿਰ ਹੋਰ ਪਰਚੀ ਹੋਣੀ ਇੱਥੇ ਤਾਂ ਮੈਂ ਪਾਈ ਨਹੀਂ ਥਾਇਰਾਇਡ ਦੀ ਕਿਉਂ ਡਾਕਟਰ ਨੇ ਪਾਈ ਹੋਣੀ ਹੈ
ਚਲੋ ਹਾਂ ਲੈ ਕੇ ਭੰਜੀ ਡੱਬਾ ਲੈ ਲਓ ਸਟੈਥੋ ਥੋੜੀ ਹੈਗਾ ਸਟੈਥੋ ਤਾਂ ਹੈਗਾ
ਉਹਨੇ ਮੈਂ ਪਾ ਦਿੰਦਾ ਇੱਕ ਆ ਸ਼ੀਸ਼ੀ ਹੈ
ਹੈਗਾ
ਬਾਹਰੋਂ
ਸਟੈਥੋ
ਲੈਣੀ ਬਾਕੀ ਦਵਾਈ ਅੰਦਰ
ਉਹ ਲੈ ਲਓ ਉਹ ਥੀਏਟਰ ਦਾ ਜੀ ਪ੍ਰਗਟ ਲਿਆ ਸੀ ਨਾ ਉਹਦੇ ਵਿੱਚ ਸਵੇਰੇ ਲੈ ਜਾਓ ਜੀ
ਨਹੀਂ ਹੁਣ ਅੰਦਰੋਂ ਲੈ ਲਈ
ਉਹ ਲੈ ਜਾਓ ਸਵੇਰੇ ਚੁੱਕ ਕੇ ਆਪਦੇ ਕੋਲ ਲੈ ਲੈ ਉਹ ਹਰਪ੍ਰੀਤ ਨੂੰ ਮੈਂ 3-4 ਦਿੱਤੇ ਉਹ ਕੱਢਦੀ ਨਹੀਂ ਬਾਹਰ ਤੇ ਥੀਏਟਰ ਚੋਂ ਲਿਆਇਆ ਸੀ ਪ੍ਰਗਟ ਮੈਂ ਲੇਬਰ ਰੂਮ ਚ ਦੇ ਆ ਫਿਰ ਵਾਪਸ ਲਿਆਂਦਾ
ਥਾਇਰਾਇਡ ਦੀ
ਇਹ ਸਵੇਰੇ ਥੀਏਟਰ ਚ ਰੱਖ ਦਿਓ
ਪੀਜੀ ਵਾਲੇ ਗਲਵਸ ਰਾਮਪਾ ਉਹ ਵਾਲੇ ਕੇਸ ਹੋ ਗਿਆ ਉਹਦੀ ਜਲਦੀ ਪਈ ਐਮਰਜੈਂਸੀ ਪਈ ਜਿਹੜੇ ਆਕਦੀਪ ਵਾਲੇ ਦੀ ਪਈ ਹੈ ਜੀ ਇਹਦੀ ਪਈ ਐਮਰਜੈਂਸੀ ਪਈ ਹੈ ਮੇਰੇ ਇਹਦੀ ਪਈ ਹੈ ਐਮਰਜੈਂਸੀ ਚ ਪਈ ਹੈ
Okay, so yeah, D,
D1.
D. All have given the answers D. Most of you.
Yes.
You think so? D is the answer. Yes.
Yes, ma'am.
If you think so, yes. Okay, so that is the right answer. Very good, right? So why? Why D is the answer? See, here the infant, the nurse is caring for infant who has respiratory distress and copious oral secretions. The question is, which finding would prompt the nurse to notify the HCP with a concern about possible tracheoesophageal atresia? Okay, so atresia. So in that case, the options, you need to focus on the options here. See, the option says that like usually in the sense the respiratory distress will decrease with oral sectioning. So if in tracheoesophageal fistula, okay, so what could be the reason for respiratory distress? What could be the reason? See, esophagus is connected abnormally to the trachea. Trachea is going to the lungs itself. Okay, in the sense the trachea's, the lower portion gets connected to the lungs itself, whereas this esophagus is getting connected to the trachea. Okay, so now if there is a respiratory distress in TEA, what could be the cause for that?
Food
What
is
could be
going
causing that?
Trachea.
Think. What could be causing distress in a baby with TEA? What's the reason for distress?
Aspiration.
Yes. Secretion. How does the secretion occur? Or what's the basic
Aspiration.
problem? Yes, what's the problem for distress?
Gastric juice.
Aspiration.
Yeah, so can you say once again?
Aspiration.
Aspiration, yes. Okay, so aspiration is the basic problem for distress. Okay, so now therefore, now when the child, like, I mean, so if something is aspirated and if the baby or if the person is showing distress, just by suctioning, will the distress be reduced? For TA, so if aspiration is the cause, fine. So will the distress be reduced just by suctioning? No, right, it will not be reduced. So this answer you cannot consider. Okay, yeah. So no tube gastric returns are greenish. Sorry, this is not a, no, it is NG. Okay, NG. NG tube gastric returns are greenish with some clots. NG tube gastric returns are greenish with clots.
No.
Why no?
Because the greenish color is from the bile. So
okay, but let me say, but there is also something to add on. So can you insert NG tube here? So if there is a TEA, if the NG tube will not reach the stomach, isn't it? So then how? Yeah. So if you insert the NG tube, it will not reach the stomach, and therefore, so without reaching stomach, how will you get gastric returns? Okay, so therefore option 2 is also wrong here. Fine, so the option 2 is wrong. So what about the option 3?
Ma'am, abdomen is distension, not flat.
Abdominal distension will be there. Very good. So why abdominal distension? More air is getting trapped. Okay, so therefore abdominal distension will be there. So not the third one. Resistance is met when trying to insert an orogastric tube. Yes, so this is the right answer. Okay, so because of that pouch that is ended, you know, so this one, so definitely, so resistance is actually met there. Fine. Okay, so whereas I was in fistula, so in the initial part while I was explaining, I was talking about the this one, the connection. Okay, remember, if it is TEA, it is atresia, in the sense the trachea is separate. Okay, so the trachea is separate. The problem is only with the esophagus here. So the esophagus is ending as a blind pouch. Okay, the esophagus is ending as a blind pouch. That is in the case of atresia. In fistula, the esophagus gets connected to the trachea. Okay, so don't get confused. In fistula, the esophagus gets connected to the trachea. Okay, yeah. So now here, so option 4 is the right answer. Okay, yeah. So moving to the next one, the nurse completes teaching teaching the parents of the 3-month-old infant who had surgical correction for pyloric stenosis. Okay, surgery was done, 3-month-old only. Which statement by the parents indicate that the teaching has been effective, in the sense parents are telling something right regarding the care of the infant or something regarding the infant's condition following the surgery of pyloric stenosis. Okay, yeah, we should use a special infant feeding device so our baby does not get so much air. We should handle our baby as little as possible right after giving the baby a bottle. Increasing the formula amount with feedings will help expand our baby's stomach. Our baby should be positioned on the right side when put back to bed after a feeding. So what can be considered as the right answer?
B.
Why?
B.
Why?
Because there shouldn't be much movement after feeding because of the surgical suture or something. But I know it's B.
Yeah, okay, but at least, like, I mean, so it's very important, but you need to make sure that the baby should be burped properly, isn't it? Okay, so that should be there. Okay, so to a certain extent, so this is also correct in the sense, like, you need to burp and you need to in the sense as little possible, in the sense you need to keep burping, but okay, don't trouble the baby much, that's fine. Whereas, is there anything better? So, or the most effective or the most right answer?
D.
D. Okay, D, our baby should be positioned on the right side when put back to bed after a feeding. What's the reason for that?
To prevent aspiration.
To prevent aspiration or to prevent vomiting mainly?
Yeah, vomiting.
Yes, basically vomiters. Okay, so to prevent vomiting mainly, fine. So sometimes if the baby, see, it's natural for the baby to vomit, and mainly if the baby vomits, you know, so aspiration can happen, fine. So that is why, so in order to prevent aspiration because of vomiting, so the side lying position is actually beneficial for the baby. Okay, yeah. So now, why side lying? Right side lying. Right side lining in the sense the stomach, the pylorus goes. You already saw in the picture, right? So the pylorus goes towards the right side. When the baby is kept to the right side, the the feed and all will easily move through the pyloric canal. Okay, and that's why, so the chances of coming up or regurgitation, vomiting will be
Where's
reduced.
green color, Momo? Give green color. Green color.
Sorry, somebody is talking. I'll just try to mute. Where is this mute? Sometimes it is not seen. Yeah, now it's seen. Okay. Fine. So yeah, so is that clear? So why right side only the baby has to be kept? Yeah, Jacob had concern, why not left side? So is that clear, Jacob? Yeah, so baby has to be kept towards the right side. So mainly because pylorus is towards the right side, and then it will help in easy movement. Okay, so that is why, so that the so if the left side of the baby is turned, so fast movement of feeding or the food doesn't happen, and thereby again there is aspiration, which which will cause, again, that could be vomitus, which will cause aspiration. Okay, so in order to prevent this, so it's better to keep the baby towards the right side, and that can be considered as the best answer. Let us focus on the wrong answers also. We should use a special infant feeding device so that our baby doesn't get much air. So what can you understand because based on this one? In which kids you use special feeding device and all? Is it required? Yeah,
Palate,
lip and
lip
cafe
palate.
palate, isn't it? So pyloric stenosis, it's not required. So option 1 is wrong. What about the other option? Option third one. Increasing the formula amount with feedings will help expand our baby's stomach. So it's not
No,
needed to
no.
increase. Yeah, okay.
Have to
So,
decrease.
yeah, so you need to give only the needed amount, not to be increased at all. So therefore, so the best answer is option D here. Okay. Yes, D is the right answer. Fine. So moving to the next one. The nurse is admitting the infant with a tentative diagnosis of intussusception. Which question to the mother would be most helpful in obtaining additional information to confirm intussusception? To confirm intussusception. Does your baby vomit after each feeding? What does the infant do when experiencing pain? Is your infant passing ribbon-like stools? Have you felt a mass in your infant's abdomen? See, all conditions, symptoms, and the rationale gets mixed here. So you need to be very clear in understanding the fact. Where did you study somewhere? Did I say somewhere where the infant draws up the leg? Did you study somewhere?
Yes,
Yes, in which condition it was?
I think intercept.
Yes,
HV, ma'am.
intussusception, isn't it? So
Fetal
intussusception.
position. Yes, ma'am.
Okay, yeah. So therefore, so what's the right answer? Option? Which one?
B.
B. Yes, B is the right answer here. Okay. So does your baby vomit after each feeding? So this is something, vomit is usually not related to this. Okay, it can occur in babies anytime, and it's not at all related to this. Fine. So, and what about the third one? Third one, ribbon-like stools occur in which condition? In which condition?
Hirschsprung.
Yes,
Hirschsprung's
Hirschsprung's disease.
disease.
Hirschsprung's disease. Okay. Yeah. So, and what about, have you felt a mass in your infant's abdomen? So mass may not be only because mass you have seen in intussusception also, and in this one also, pyloric stenosis also. So yeah, isn't it? So now mass may not always indicate this problem. Okay, so whereas the best thing is, what does the infant do when experiencing pain? When there is obstruction, so there is a drawing up of legs. We have already discussed while explaining the conditions. I had explained that. So therefore, option 2 is considered as the right answer. Okay, yeah. Now, so we'll stop here now with these questions, and we'll do the questions later. So I would now like to begin with medications. Okay, some of the important gastromedications. Fine. And let me also inform you all. So next Thursday. Okay, so let me just, on 13th, there would be a session. See, Thursday, you generally don't have any classes, but next Thursday, there is a special class on pharmacology. Okay, so only on pharmacology, we are going to schedule a class. So at the same time, so be available. It may not go up to 3 hours, around 2 hours. Okay, so on next Thursday, on 13th. Fine. Okay. So anyways, it will be intimated you in via Teams, right? Early, before the class. Okay, so now let me just move to the next topic. Pharmacology. Okay, the first, see here mainly we have discussed lots of medications that are usually used under the gastro. The first thing that we are going to while during the conditions I had mentioned about a few medications, isn't it? So now let us go in detail about these. Okay, so let us go in detail about this. The first thing that you are going to learn is something on antacids. Antacids, fine. So you know what antacids usually does? Ribbon-like stool, Hirschsprung's disease. So Hirschsprung's disease, okay? Yeah, fine. So antacids. So antacids in the sense they are against the acids. See, our stomach keep producing the acid, and this acid is required, but it's required to mix with the food, and it's basically required to kill the bacteria, and also this acid is required. Our stomach has to be in its acidic state itself, fine. But sometimes these acids can actually cause lots of irritation to the mucosa, ending up in gastritis and all. Okay, so therefore antacids are taken to neutralize the acids that have been already produced. Okay, what does antacids do? They neutralize the acids that have already been produced. Okay, so therefore, so these antacids are actually given. So now it is available in syrup forms as well as in tablet forms and all. But remember some very important points here. So antacids should be taken 1 hour before or 2 hours after oral or other medications, which means antacids will interfere in absorption of food and medications and all. Therefore, it should always be taken separately. It should always be taken separately. Okay. So, however, so now like when taking antacids, there are different kinds of preparations, like aluminum hydroxide preparation is there. So then what next? Calcium carbonate preparation is there. Magnesium hydroxide is there. Sodium bicarbonate is there. Okay, so these are the different kinds of preparations, right? So let us learn a few important points associated with each of these. Aluminum compounds mainly cause constipation. So this is one important point that you need to know. Aluminum compounds, okay? So therefore, when a client is given with aluminum based antacids, you know, so you need to keep in your mind that so constipation is a common problem here. That's the most side effect. Okay, and this aluminum, so this aluminum hydroxide preparations have got two important interactions. One is for people who are having hypertension and all, it is contraindicated. Please write it down. Okay, so for cardiac problem patients, it is complicated. Why? Because this aluminum will have sodium in it. Okay, so sodium component is also present in it. So therefore, for cardiac patients, very carefully with caution, you will have to administer. Okay, so apart from this, so it will reduce the effects of certain drugs. It can reduce, it is only a possibility. Okay, so it can reduce the effects of warfarin. So please write it down. It can reduce the effects of warfarin. So digoxin, okay, which means that the effect of these medications will get lower. Okay, so it will reduce phosphate absorption. So these aluminum preparation can reduce phosphate absorption. Okay, so and also it can reduce the effect of tetracyclines. So these four category of drugs the effect of these drugs can be reduced basically when aluminum compounds are actually used. Okay, so therefore, so these are the important points under the this aluminum rich aluminum hydroxide based antacids. Okay, yeah, coming to the magnesium hydroxide. Magnesium usually causes what? Diarrhea or constipation? Diarrhea, isn't it? So
Diarrhea.
it usually causes diarrhea. So therefore it should be obstructed in intestinal obstruction, in appendicitis and all, where I had talked in the adult disorders. We talk like there are certain conditions where laxatives should be avoided, isn't it? So which are those conditions? Any bowel obstruction, or even in what was that condition? Appendicitis, isn't it? So in these conditions, no laxatives should be given. So magnesium, since it causes diarrhea, it should be avoided in those conditions. Remember, okay? Yeah. So, and it can cause alkalosis and also reduced absorption of calcium, iron, and most medications. But also there is a calcium carbonate preparation also. Calcium carbonate will also cause constipation. Okay, sodium carbonate preparations mainly causes hypertension, heart failure, which is also there in aluminum products. Okay, yeah, so these are the main. Remember about the constipation and diarrhea causing antacids. Remember about the caution, and also remember about the effects of aluminum hydroxide on certain drugs. Okay, and antacids in general, it should be taken separately, not to mix with any other food. Fine. So next category of drugs are histamine receptor antagonist. Histamine receptor antagonist. Okay. So in the sense, so antagonist in the sense, see, antacids were neutralizing acidity, whereas this H2 receptor antagonist, what are they going to do? They suppress the production of the acids itself. Okay, so that is what they are going to do. They totally suppress the production of acids. Okay, so that is what this H2 receptor antagonists are going to act. Okay, like specifically Rantac is considered as the safest, ranitidine and all. Cimetidine is a little cautionly you will have to use cimetidine. Okay, so cimetidine basically it will cause CNS side effects. Remember. Okay, so CNS side effects mainly cimetidine will cause. Cimetidine. So that is the main thing that you need to remember here. Okay, yeah. Proton pump inhibitors are also the omeprazoles, esomeprazoles, Zerdo-LE drug, ending drugs. Fine. So proton pump inhibitors. So usually this is also given in peptic ulcer or ulcers in the esophagus, or in Zollinger-Ellison syndrome. Okay, you learned under the peptic ulcer, isn't it? Zollinger. So in those conditions, this proton pump inhibitors are usually given. Okay, yeah. So again, the same thing, not to give with antacids, and that's it. Okay. Yeah, so now let me add on here only. There are some H. pylori against the medicines that act against H. pylori too. Okay, so this for H. pylori, remember I was talking about there are 3 kinds of therapies that are given basically for H. pylori infections. So one is a dual therapy, triple therapy, quadruple therapy for H. pylori. So remember mainly there is dual therapy, dual, okay, triple and quadruple. Dual, triple and quadruple. Okay, so therapies are given. So what is this dual therapy? Dual therapy in the sense like I mean, so see for H. pylori only antibacterial agent is not going to have a great effect. It is not going to kill the bacteria. Okay, so dual therapy in the sense there will be one antibacterial agent and one the either H2 receptor or likewise any drugs will be there. Triple therapy in the sense, so there will be antibacterial agent, proton, 2 antibacterial agent will be there and 1 proton pump inhibitor will be there. Okay, so usually triple therapy is successful. For triple therapy, you need to understand 2 antibacterial agent will be there and this one they will be given together. Triple therapy fails, then we go for quadruple therapy. Okay, so quadruple therapy in the sense 2 antibiotics, 1 proton pump inhibitor and 1 H2 receptor. Okay, that is in quadruple. 2 antibiotics, 1 proton pump inhibitor and 1 H2 receptor. Okay, so these are the the therapies that are usually provided for H. pylori infections. That clear? Okay, yeah. So moving to the next one, antiemetics. Antiemetics here. So antiemetics have got an anticholinergic effect, isn't it? So cholinergic, anticholinergics under cardiac system, under neuro, where all we discussed about the anticholinergic effect. So what are the common effects of anticholinergic drugs? So that they are given in red here: drowsiness, hypotension, dry mouth, photophobia. Haven't you learned? Yes. So these antiemetics have also got anticholinergic effect. So therefore, so when a client is on these antiemetics, you should be monitoring for the signs and symptoms of anticholinergic drugs. Okay, like you need to focus on in the sense all the drying effects and all. So anticholinergic effects mainly. Okay, like dry mouth is common. Then what? Monitoring the urinary out. Think, give me answers also before I say. Urinary retention is there, isn't it? So then what else? Constipation. Yeah, very good. Constipation would be there. So anticholinergic. Dry mouth. Yeah, exactly. So what you should, you will be advising, you need to, those who are on antiemetics and all, they should be advised to increase fluid intake. Yeah, increase fluid intake. Fine. So then what else you can provide to them to relieve the dry mouth and all? So how can dry mouth be prevented in them? Yes, by giving some sugar-free chewing candies, gums and all can actually be provided. Okay, yeah, so in that way, so you can help in reducing the dry mouth. Of course, you need to focus on the vital signs. Okay, yeah, so like these things you need to know. And specifically, I want to talk about this Reglan, metoclopramide or Reglan. Okay, Reglan will be causing extrapyramidal symptoms. In the sense, extrapyramidal symptoms in which condition did you study? EPS.
Parkinsonism.
Parkinsonism, very good. Extrapyramidal symptoms. When a client is on a metoclopramide, he can show some Parkinson's symptoms. In that case, you will have to stop the medication. Okay, so you have to stop the medication. So that is very important here. So sometimes metoclopramide. Okay, so these metoclopramide, so usually can show up with some extrapyramidal symptoms. Okay, so that's very importantly fine, you need to note there. Okay, yeah, so that's it. So about the metoclopramide and all. So moving to the next one. So just a second. So this, yeah, one moment. There is some. Can you see the screen?
Yes,
is the
ma'am.
screen?
Yep.
Yeah, now it's there, isn't it? Okay. So I was talking about these antiemetics. Remember about the metoclopramide. Okay. So, and you need to focus especially for this EPS symptoms. Fine. So if EPS symptoms are seen, so mainly you need to stop the medication. So that's very important. Okay. Yeah. Moving to the next category of drugs. So that is antispasmodics. Antispasmodics in the sense, so usually when pain or spasm is felt, so these medications are usually given. So antispasmodic examples, you generally know, it's already given there. So but still in the sense when the spasmodics are taken, okay, so you need to monitor for the daily pattern of bowel activity, stool consistency. So this is important. It can also have constipation, dry mouth, urinary retention, blurred vision. So these kind of problems can be present. Okay, yeah, nothing more to learn about it. You can just leave it. Coming to antidiarrheals. Antidiarrheals, very common antidiarrheals are Lomotil, Loperamide, Imodium. So these are very common antidiarrheals that are basically used. Okay, so now here when a client is on antidiarrheals, so what are the necessary factors that are involved? So mainly under the side effects, you can already see, like, so these are some of the common side effects which are basically caused by the anti-diarrheals, isn't it? So like this one, constipation again, paralytic ileus, dry mouth. So these are the problems. Of course, for that, the interventions are the same, whereas I want to add on a few points here. So especially the dosage of Lomotil. Okay, so please note the dosage of Lomotil. The dosage of Lomotil in the sense, it should be this diphenoxylate. It is also called as diphenoxylate, and this diphenoxylate initial dose can be 4 mg. Okay, but the maximum dose in a day should be 16 mg. Initial dose 4 mg, maximum dose in a day should be 16 mg. Okay, so like after giving initial dose, if the client again passes a loose stool, so then you can give 2 mg dose, not 4 mg. Okay, 2 mg dose has to be given. Okay, so this is one point that I had to focus here. And what is diarrhea diet? See, for gluten, I had talked about bro diet, isn't it? So for celiac disease, I have talked about the bro diet that should be avoided. So avoided. But I want you to, do you know what is the diarrhea diet called as? For diarrhea, what diet you give?
Ma'am, what? BRAT?
Brat diet. Yes, very good. Brat diet. Okay, so banana, rice, applesauce, tea or toast.
Toast.
Yeah, banana, rice, applesauce, tea or toast. So this is the diet that is followed. Okay, so for diarrhea, fine. Okay.
Ma, please, sorry for cutting you short. I don't get the thing you said about the dosage.
Dosage. I mean, so for initial, see, for the first time when the client passed the loose stool, the initial dosage is 4 mg. Okay, yeah. So then this dosage should be in a per day, it should be maximum 16 mg. So it can be less than that, but not more than 16 mg. In the sense, yeah, what I meant was like for every next passage of loose stool, the client can be given with an added dose of 2 mg.
Okay.
Okay, yeah, so an added dose of 2 mg in the sense like every time, so initial dose was 4 mg, and after a half an hour, if the client passes loose stool, you can give 2 mg.
Okay.
So this 2 mg can be given for the next 6 times, in the sense initial 4 mg. For the next 6 times, if the client is passing loose stools, you can give 2 mg. So total it will be 12 mg, isn't it? So 12 plus 4 will be maximum 16, not more than that.
Okay.
Is that clear? Yeah.
Thanks.
Yeah, okay, fine. And what about caffeine? So can caffeine be provided for diarrhea? Caffeine?
No
caffeine. Okay, caffeine will increase diarrheal symptoms. It will exacerbate diarrhea. Okay, it will increase GI motility. So therefore, caffeine should not be provided. Okay, yeah. So because these options, see, this seems to be very simple, but when they give in the options, you know, we get confused. So that's why I had to focus on these points. Fine. Coming to the laxatives. So laxatives, what it does, you already know. Psyllium, biscacodyl, sodium phosphate. These are the ones. Psyllium and all. Psyllium acts under the bulk forming agent also. Bulk forming agent. Okay, psyllium. It acts like a dietary fiber, the psyllium specifically. Fine. So when laxatives are given, it is contraindicated in bowel obstruction. We had already discussed about this, isn't it? So in intestinal obstruction, in appendicitis and all, never give laxatives. Very important point. Okay. Yeah. So then increase fluid intake, monitor bowel movements, administer at bedtime. So usually bulk forming laxatives like psyllium, yeah, this I already told you, it acts like a dietary fiber. So you can take it with a full glass of water. Okay, so this laxative, so you can take it with a full glass of water. So that's what about the psyllium. Okay, Yeah, and the general aspects under the laxatives. Yeah. Bile acid sequestrants. What do you understand by this? Bile acid sequestrants. See, when bile absorption is not happening, see, bile has to actually get accumulated, in the sense it should come out through the fecus itself. So, but sometimes, so bile will stay unabsorbed in the intestine. It will not be absorbed by the food. In that cases, so these bile acid sequestrants will make sure to bring in the it will absorb all the bile salts, and then it will be removed through the feces. Okay, yeah. So therefore cholestyramine, so this is commonly used, cholestyramine, cholecystipol, so these are the commonly used one. The side effects are constipation. It can cause constipation, fecal impaction, intestinal obstruction, and all. Again, so these agents are avoided in intestinal obstruction. Okay, yeah, sometimes the condition can get worsened. So therefore, fine. So these were some drugs under the gastrosystems that you had, gastrosystem that you had to know. Okay, so that's all about the drugs. And let us get back to a few conditions. So do you have any doubts regarding these drugs? So that we were discussing. Yeah, when you do questions, you may get some doubts. Yeah, so please focus on only the important points have been brought up under the drugs, through which questions they are the points where the questions usually focus. So we can't keep learning each and everything, isn't it? So many drugs are there, and of course pharmacology is very important for NCLEX, wherein you get 15% of questions, and if you don't answer well in pharmac, so the passing probability is greatly reduced. So therefore, preparing pharmac is very, very, very important. Okay, yeah. So,
please, can you throw more light on the bile acid drugs? Because I don't get where, if bile is not as absorbed well,
yeah,
it absorbs the salt and then passes it through the stool. So I don't get the.
See, this bile, you want to know how the mechanism of bile?
Yeah, I don't get the mechanism of action of the drugs.
Drugs.
I didn't get the mechanism of action
of this bile acid.
Yes.
Okay, so now see here, actually bile acid sequestrants are basically the drugs that will help in absorbing the bile. Okay, so that is what you need to know, like in the sense mainly the bile salts absorption, it will have a greater effect on that. So conditions like when a client is having jaundice and all, so what will happen? The bile salts are not getting absorbed, isn't it? So what will the bile salts so it will be freely released in the blood. Fine. So now in that case, so these bile acids, so when these sequestrants are usually given, so what they generally do is like they help, or they stick to the in the sense they attach to all the bile salts, so that are easily distributed. So it could be in the arteries and all, whatever the bile salts are present. So these drugs will be absorbing the same. Okay, and so they will make sure that the bile are not freely flowing into the bloodstream. When these medicines are given, they absorb the bile that is present in the blood, and they will make sure that this bile doesn't flow in the blood. Rather, so these medications, what it will do, so they will absorb the bile, and they will put it in the, or they will absorb in such a way that the intestine will be receiving it. Okay, and then it is so it is mixed with the feces, and then the bile is let out. The basic function of this bile acid sequestrants is to make sure that is to reduce the level of bile salts. Okay, so that is why it is given. Bile acid sequestrants are usually given. Okay, so even in people who are having too much of cholesterol levels and all also, so these bile acid sequestrants are actually given. mainly those who are having lots of cholesterols. Is that clear? So that is the basic purpose of why this bile acid sequestrants are usually given and how this actually works. Okay. Is that clear? Yes, Amanda. Amanda was asking, right? Are you
Can
there,
it be
Amanda?
given in, can it be given in cholecystitis? The inflammation of the bowel, can it be given in such condition?
Cholecystitis, it again sometimes it can be given. So if there are, if too much of bile salts are there, so it can be given, but it should not be given in conditions where the bowel is obstructed. Okay.
Okay.
Yeah. Wherever
Thank-
any conditions where bowel is obstructed, so it should not be given. Yeah.
Okay.
So, but it is mainly given with for clients who are having very high levels of cholesterols. For them, this is given mainly bile acid sequestrants. Okay.
Oh.
Yeah. So yeah. So
Thank you.
and yeah, fine. So that's something on bile acid sequestrants. And any other questions?
Then in the laxative, the classes of laxative, there are different types of laxative and what they do. Like this, you said the bulk forming ones are the phylums. The Bisacodil, that's the Ducolax.
Yeah.
Yeah, it does. What's the mechanism? There are like 5 classes, and I find it hard to get like what each one do, because I've come across one of the questions where they specify what type of laxative and what does it do.
Okay, so in the sense like mainly we can say like see the xylem and all come under the bulk forming laxatives. Okay, so xylem and all, they come under the bulk forming laxatives. And apart from that, so there is also laxatives like Biscodil, Biscodil and all. So what they do is they stimulate the muscles of the gut. Okay, they just keep stimulating. Okay, Biscodil. Yeah, Biscodil stimulate. They are classified under stimulants, laxatives. Okay, yeah. And apart from that, there is also another category called as lactulose. Lactulose is usually given in cirrhosis of liver. So we had discussed there, isn't it? So they absorb in the sense bulk absorption of I mean, so it is there. Yeah, so it will help in removal of the ammonia, and therefore it comes under the osmotic laxatives, because they basically pull out more water. Okay, so that's why it is called as oxidative osmotic laxative. So these are the main 3 categories of laxatives.
Okay, so the bulk forming, the stimulants, and the osmotic
diuretic. Yeah.
Okay, thank you.
Okay, yeah, fine. So anything else?
Osmotic, which one? Osmotic laxative.
Lactulose, 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 which is used for cirrhosis of liver. There I had discussed. Okay, yeah. Anything else? So how is the question based on the classification of laxatives, Amanda? Could you please explain that? That could be helpful for others also. How was the question?
Personally, I can't remember the question, but I know it was sort of talking about the mechanism of action of one of the, I think it was the one of the osmotic pressure. What osmotic laxative.
Yeah. Okay.
It was, so it states like this laxative, how does it function? So that you need to know each of them what they do and how they function. So I think that was what the question, and I saw it in UWorld, I think.
Yeah, okay. See here, basically the question was also there on xylem. Okay, that is the bulk forming laxatives. So it was there like in the sense we had discussed under diverticulitis that those bulk forming agents can be given. Okay, so for diverticulitis, so the question was like under the medication chart, which is acceptable. So that was the question. So since you learn here, so xylem come under the bulk forming, so therefore it definitely can be given. So bulk forming laxatives, mainly xylem, they act as a dietary fiber. So a fiber rich diet has to be given for diverticulitis, but only when the inflammation occurs. So we need to reduce the high fiber diet. So that is what you learned under the diverticulitis. Now the question was, so which is acceptable? So that was the question. There were a numerous medications list, and xylem was also there. Okay, so and you could have selected that there. So those kind of questions you will get. Okay. Yeah, but thanks for adding this classification. I didn't know that they were asking the that kind of question was there. So from when you give these kind of suggestions, you know, so that will help me to add those kind of examples also in the next class. Okay, so thank you for that. Okay.
This milk of magnesia will come under which category? Milk of magnesia.
Magnesium goes under this one, the lactulose kind of osmotic.
Okay. And
yeah.
polyethylene glycol.
Which one?
Polyethylene glycol.
Polyethylene glycol and all go under this. More will be water changing itself or pulling the water from the body. Okay.
Okay.
Diarrheal effect. Yeah. Okay. So yeah, we'll move to the questions now. There are also some pancreatic enzymes. So I think we had just the names you have to know. The pancreatic enzymes, pancrelipase, pancreatin. You know in which conditions it is usually given, isn't it? So for in pancreatitis and all, when there is escape of pancreatic enzymes, so usually this will be helping, right? Okay. So pancreatic enzyme. Okay. So let me open the questions. We have a few more questions on the conditions. Let us finish this. The nurse is caring for the infant with did I discuss? Yeah, I did not discuss, isn't it? So the nurse is caring for the infant with Hirschsprung's disease. Which statement? Did we discuss this? A similar kind of question. I'm getting confused.
No, ma'am.
We didn't discuss, isn't it? Yeah. Which statement by the parent indicates understanding of the treatment for Hirschsprung's disease? Our baby's symptoms can be controlled with a low fiber diet. Our baby will need a permanent colostomy surgically placed. Our baby will be given enemas daily until the stools are normal. Our baby will need an operation to remove the diseased bowel.
D.
Which statement
D.
indicates understanding of the treatment of Hirschsprung's disease? Yes, that is very clear, isn't it?
Yeah.
So what about the option A? Low fiber diet?
High fiber diet.
Actually
fiber.
here, no, high fiber diet also, see, the question is based on the treatment. Okay, so what understanding does the parent has based on the treatment? So what's happening in Hirschsprung's disease? You should avoid the accumulation, isn't it? So you should avoid the accumulation. So therefore, you have to put the baby on low fiber. Yeah, so in the sense you have, but this low fiber diet is not going to control the symptoms. Okay, yeah. So therefore, option A cannot be selected. So what about the option 2? Permanent colostomy? No. Isn't it? Yeah, after repair, so that will be healed. Only that is temporary colostomy. Okay. So what about the third one? So our baby will be given enemas daily until the stools are normal. In the sense, so when stools are normal, daily enema?
No.
When
no.
it is given? Not daily. Okay, so daily it's not required. Especially focus on the frequent. Usually, you know, this frequency based questions, you need to, whenever they mention give 2 times or 5 times, or give only this, or those kind of questions, usually you need to, mostly they are wrong. Okay, when those options are there. So usually you need to focus on this, how it comes, the type of question. Our baby will need an operation to remove the diseased bowel. Yes, this is right. Okay, so that is 100% right, and therefore, so that was the correct understanding of the treatment. So see, the option 1 is also right. You have to put the baby on low fiber diet so that accumulation will be avoided, but that is not going to stop from the problem, isn't it? So therefore, the question focuses on what is the best treatment, understanding of the treatment, and therefore option 4 is considered as the right answer. The next one. The oncoming shift nurse is receiving or reviewing the documentation completed by the previous shift nurse in the medical record of the 16-year-old client with ulcerative colitis. Which statement in the narrative notes should the oncoming shift nurse most definitely clarify with the nurse from the previous shift? From the previous shift. 75% of low protein and low carbohydrate breakfast meal of bran muffin, milk and orange juice. Antispasmodic given before breakfast, effective. No abdominal pain or cramping after eating. Child and parent instructed on azathioprine being used to wean the client off the steroids. 4 loose bloody stools this shift. Taught on use and application of barrier cream for skin protection. Most definitely clarify document is which one? So that is the question. Any answer? Try. Get back to the question again. See, if the oncoming nurse has to clarify, you know, so there should be something wrong in the notes. So that is why she is doubtful and she's trying to clarify. You need to think in that way. For ulcerative colitis, what could be the doubtful notes that is mentioned here? 75% of low protein, low carbohydrate.
A.
A?
Yeah, because they have absorption problem already. So they need high protein and high carbohydrate.
Yes, okay. So they should require high protein, because for ulcerative colitis, so you need to understand high protein and high carbohydrate diet, not low. Okay, so whereas the fiber should be decreased there, because ulcerative colitis and all, so we'll be having usually what, like too much of diarrhea will be there, isn't it? So now bran, muffin and all consist of high fiber. So therefore, so this is wrong. So whereas here already there is 75% of low protein, in the sense that's already, that's really low. Okay, so therefore A can be a concerning. But what about the other options? Antispasmodic given before breakfast, effective. No abdominal pain or cramping after eating. So what does that indicate? So before means you can give antispasmodic, so that is right. Okay, yeah. And third one, azithromycin. What is this azithromycin? Have you heard of this before?
Immunosuppressant.
Yes, exactly. Okay, so that can be given. Okay, so what about the last one? See, loose stools. Yeah, see, that is expected, right? So loose stools is something so that you can definitely expect there. Okay, yeah. So therefore, so this can be considered as the wrong answer, and the sense which is normal. and therefore, so option A is considered as the right answer here. Okay, yeah. The clinic nurse completed teaching with the adolescent who recently started treatment of peptic ulcer disease caused by H. pylori. Which statement made by the client indicates the need for further teaching? I'll keep my antibiotic and antacids in my backpack so I can take these when at school. I should stop drinking caffeinated soda because it increases my abdomen pain and is irritating. Other members of the family could have H. pylori or should be checked for contamination. I was surprised that breathing test I completed could determine whether or not I had H. pylori. And what is the question? The need for further teaching in the sense, one option is actually wrong. Okay, so which is that?
Option D.
Option
D.
I should stop drinking caffeinated soda because it increases my abdominal pain and is irritating. Okay, so what about the next one? Anything else?
C1, third one, ma'am.
H. pylori is transmitted, do you think so?
No.
How it is transmitted? See, need for further teaching means what? You are getting confused here with the question.
I think it's option D.
Yes. No, let me just tell you, ask you, see why the questions are changing. 1 second. Yeah, this was the question, isn't it? So here the question, which statement by the client indicates the need for further teaching in the sense what? So there is a statement which is wrong.
I think it's D. I think it's C. C
is wrong. Other members of my family could have H. pylori. Should be checked for contamination. Why did you say it's wrong?
I don't think it can be contaminated from water or from the well.
But water supplies can become contaminated. Do you know why? H. pylori's transmission is through fecal-oral routes. Okay, so fecal-oral routes, yeah, so that's why. So well water can become contaminated. Yes. But why did you say B? B in the sense somebody answered here B. B, it is right? So like caffeinated soda and all there, so it should be stopped. Okay.
I think it's option D, ma'am. I was thinking what's the relationship of breathing test to check for the H. pylori.
I was surprised that the breathing test I completed could determine whether or not I had H. pylori. That is a diagnostic test, isn't it?
Yes.
Yeah, so that is also right. What's wrong in that? So that's also right. Whereas option 1 is wrong here. So option 1, do you know why? So do you know why it is wrong? Yeah, you cannot.
Orange.
No. You cannot allow it to carry in a backpack because that is unacceptable. Okay, so the school authorities have to be informed. So before the antibiotics are taken. Okay, so I can take these when at school. So that is not the right. I mean, so in which statement made by the client indicates the need for further teaching in the sense there is something wrong in the statements by the told by this person, this adolescent, and you need to give further clarification about that. So which is that statement is asked here. Okay, so taking medications at school is actually unacceptable without the permission. So it should be like the doctor has to get a permission, in the sense the appropriate personnel has to appropriate personnel should be giving permission. A school nurse and all can give a permission, and after that only so it can be carried. Okay, so therefore in the sense it will be kept in the school itself. So that's why, so option 1 requires further clarification. The question was further clarification. Okay, and that's why option 1 is considered as the right answer. Fine. Okay, yeah, so we'll move to the next one. The infant who is unable to suck effectively requires gavage feedings. Okay, the infant is unable to suck effectively, requires gavage feedings. Which statement best describe the proper protocol the nurse should follow when feeding the infant via gavage feedings? The correct way. This is a SATA question. The gavage tube can be inserted in either mouth or nose. The feedings should be similar in amount to the bottle feedings. Continuous feedings rather than intermittent feedings are preferred. Aspirate stomach contents before feeding and discard the aspirates. Warm the gavage formula to room temperature before starting the feeding. So this is easy question. Can you just, if you just think a little more, so you will get the right answer for this. Can it be inserted through mouth or nose?
No, only
Yeah.
mouth.
No, it can be inserted.
Yes.
Yes, yes. Okay, that's right. Orogastric is allowed. Orogastric and nasogastric. Yeah. So orogastric is fine. Yeah, definitely. Option 1 is right. So what about the second one?
Yes.
That's also right. Yes. Okay. So what normally the child takes, to the same amount it should be calculated, isn't it? So what about the third one?
No.
No, not continuous, intermittent, so that the child will have a feeding of the similar routine that the child was following before this tube insertion. Okay. Yeah. So what about the this one, the fourth one?
No, wrong, ma'am.
Wrong. Okay. So wrong. I mean, so it should be reinserted. It should not be discarded, isn't it? Okay. So what about the fifth one?
Yes, true. Yes, ma'am.
Warming has to be done, right? So that further cold, chilling and all can generally be avoided. So therefore, option 1, option 2, and option 5, A, B, and E are the right answers. Okay. So A,
Sorry,
B.
Is gavage feeding the same thing with NG feeding?
Yes.
Okay.
Okay. Yes.
So it's the same thing with the gastro.
Yeah. Yes.
Okay.
Okay. Yeah. Fine. So we'll move to the next one. A client with peptic ulcer is diagnosed with H. pylori infection. The nurse is teaching the client about the medications prescribed, including clarithromycin, esomeprazole, and amoxicillin. Okay. See, so this all come under the dual therapy. Which statement by the client indicates the best understanding of the medication regime? My ulcer will heal because these medications will kill the bacteria. These medications are only taken when I have pain from my ulcer. This, whenever you find only, so you need to have a second thought there. So the medications will kill the bacteria and stop the acid production. These medications will coat the ulcer and decrease the acid production in my stomach. What would be the best answer? See, you can yes, very good. The answer is clear. Clarithromycin antibiotics are there, and esomeprazole is there. So proton pump inhibitors are there, isn't it? So they stop the acid production. Okay. So therefore, option 3 is the right answer. Okay. Yeah. So like usually Yeah, this is coming under triple therapy, not dual therapy. So 2 antibiotic bacterial medications are there, isn't it? So it comes under triple therapy. 2 antibacteria, 1 proton pump inhibitor comes under triple therapy. Okay, yeah. So therefore, so this comes as the right. Option 3 comes as the right answer. Fine. So the next one, a client who uses NSAIDs has been taking misoprostol. Under what does this come, misoprostol? Any idea? Misoprostol. Misoprostol goes under.
Progesterone agonist. Progesterone agonist.
No. Misoprostol are gastric. Yeah,
Prostaglandin.
they are gastric protectants. They are the ones that will sucralfate and all you would have heard, isn't it? So sucralfate, misoprostol. Okay, so they are usually given with meals, and sucralfate and all can be given on an empty stomach also. So here, remember, under misoprostol, sucralfate are the 2 commonly
Gastric
given
protectants. It's
protectants.
gastric
Yes,
protectants.
protectants. Very good. Okay, so they are misoprostol and sucralfate. They are commonly given gastric protectants. Okay, so now misoprostol usually causes diarrhea, whereas sucralfate can cause constipation. Okay, sucralfate can cause constipation. The sucralfate, you know, it can reduce the absorption of warfarin, phenytoin also. Okay, and also digoxin and theophylline. Warfarin, phenytoin, digoxin, theophylline. So these drugs actions are reduced when sucralfate is used. Okay, yeah. So it misoprostol come under gastric protectants. Okay, yeah. So now therefore, now here what could be the right answer? What should be the therapeutic effect?
Ma'am, second one.
Second one. Very good. Okay, so second one is the therapeutic effect. Okay, yeah. So moving to the next one. The nurse determines the client needs further instruction on cimetidine if which statements were made. SATA. I will take cimetidine with my meals. I'll know the medication is working if my diarrhea stops. My episodes of heartburn will decrease if the medication is effective. Taking the cimetidine with an antacid will increase its effectiveness. Okay, so I will notify my healthcare provider if I become depressed or anxious. Some of my blood levels will need to be monitored closely since I also take warfarin for atrial fibrillation. This is the F1. Okay, yeah, so these many statements are there. So what all did you learn under cimetidine?
Anticholinergic effects.
Yes, so cimetidine antagonistic effect. So which all answers can be selected here? In the sense, the question is which answers are wrong. The nurse determines the client needs with further instruction on cimetidine if which statements are made. Can it be taken with meals?
No.
No, it should be taken with empty stomach, isn't it? Yeah, that's so option 1 can be considered. I'll know the medication is working if my this one diarrhea stops. No, that's not right. Okay, yeah, so therefore you can select that. Second one is also right answer. My episodes of heartburn will decrease if the medication is effective. That is correct.
That's
correct.
Correct.
That's correct. That's correct.
Correct.
Okay. Yeah. So you can select. I mean, so you should not select that for this question here. Yeah. So taking cimetidine with an antacid will increase effectiveness.
No.
Decrease. So you can select this as answer. I will notify my HCP if I become decreased or anxious. Yes. Some of my blood levels will need to be monitored closely since I also take warfarin.
Yes, ma'am.
Yes, ma'am.
That is right, isn't it?
Right.
So yeah, because like usually cimetidine, when a client is on cimetidine, you know, so warfarin and all dosage, it can be interrupted. Okay, so therefore that is right. So which are all the right answers for this question? Which are right answers? A, B, and fourth one,
D.
isn't it? Yeah, D is the right answer. That's it. Okay. So this was a negative query question. Hope you are understanding the differences between a negative query and positive query. When you get these kind of
Please,
words.
does cimetidine cause depression and anxiety?
Cimetidine?
Is
Yes.
it like a side effect?
Yes, yes, because it crosses the blood-brain barrier and it acts on the central nervous system. So that's why. Okay. Yeah.
Okay.
So please focus on these, like when needs for further instruction is there, you know. So you need to understand that you need to select the wrong statements or the incorrect aspects regarding to the care or whatever the questions they have put. Okay. Yeah. So moving to the next one. A client has a new prescription for metoclopramide. On a review of the chart, the nurse identifies that, so this medication can be safely administered with which condition? Intestinal obstruction, peptic ulcer with melena, diverticulitis with perforation, vomiting following cancer chemotherapy. Metoclopramide, what was it?
Antiemetics.
Antiemetic. So
Answer
tell
is
me.
D.
Answer
D.
is D, isn't it? So answer is D. So that's right answer. Okay. Yeah. So moving to the next one. The nurse has given instructions to a client who has just been prescribed cholestyramine. Which statement by the client indicates a need for further instruction? I will continue taking vitamin supplements. Is it right or wrong? With cholestyramines, is vitamin contraindicated?
No.
No. Okay. Yeah. So what about this medication will help to lower my cholesterol?
Yes, it is right.
Yes, that is right. Okay. So this medication should only be taken with water.
Yes.
Can't you take with any other forms like fruit juices and all? Should it be taken only with water? No, it can be taken with fruit juices also.
Yes,
okay. A high fiber diet is important while taking these medications. High fiber diet.
Because it causes
constipation. Yeah, you all learned these points, but this is how when it comes in the questions, you know, so how this is you learned constipation while studying. Okay. So constipation is the side effect, but see how the question, how they have put the answer. High fiber diet is important. So that is how you need to relate us, because constipation is what I have studied. High fiber diet can be considered as the right one in regard to the cholestyramine. But the question here is like indicates a need for further instruction, which means that, so there is a wrong statement, and the wrong statement is the third one. It can be taken with other juices also, not only water. Please note these words. Okay, as I told you, when only and all comes in any statements, you know, there is nothing like only one thing that you can do in most of the options. Okay, so like usually you can consider only provide oxygen, only eat high fiber. Sometimes it will these options, if it comes, you know, easily, when you are really confused with the other ones, you can consider this as the odd one that has to be out. Okay. Yeah, so option C is the right answer. Okay. Yeah, so now that was all about the conditions that we had to discuss in today's session. Do you have any doubts? Do you have any doubts? It's a weekend, and please prepare yourself for the gastro assignments and also and try to solve that by tomorrow, day after tomorrow, or at least by the end of next week, after reviewing once again all the contents. Through when you do questions, you know, you will learn many other new facts also. Okay, so that's why doing those are very important. And any questions for clarification? Okay, so yeah, does somebody? No? Okay, so as I already told you, those that have not started with the registration with APRA, please start your process because it's a time consuming one. And by the time you finish studying these aspects, you should be able to give your exam. Otherwise, it is of no use because you will forget. Okay, that's why. So by once you have started this course, like by like after 3 or 4 months, you should be able to attempt the exam. Okay, so because ATT is taking more time, so that's why. Okay, yeah, so please finish your registration, complete that as soon as possible, and apply for ATT. And once you get ATT, so soon book your exam too. Okay, yeah. So that's all. See you next week. Take care. Bye. Good night.